Welcome, everybody, and thank you for joining us today. We are here with Dr. Tyler Johnson, who is an associate professor and medical oncologist at Stanford Healthcare. So let's get started. Before we begin, Dr. Johnson, could you start by telling us a little bit about yourself?
Sure. As you said, I'm a medical oncologist at Stanford, which means I'm the kind of doctor who gives chemotherapy to people with cancer. And I specialize in people who have what are called GI cancers. So the cancers that my patients most often have are colon cancer, pancreas cancer, and then a relatively rare kind of cancer called a neuroendocrine tumor, although I take care of people with a number of other different kinds of cancer as well.
So all of those cancers that you noted all play very critical roles in hormone production and signaling throughout the body. So what is it like to manage tumors that affect very interconnected and complex systems in the body?
Yeah, that's a great question. So there's kind of two ways of thinking about something like that. So on the one hand, for example, we have something like a neuroendocrine tumor. Neuroendocrine tumors are unusual in that they actually secrete active hormones, not all the time, but sometimes they do. And that can make managing them very complicated because, for example, they can secrete insulin. But unlike your pancreas, which secretes insulin in a very carefully controlled way and only when your body really needs it. If a tumor is secreting insulin, it just secretes however much insulin it wants whenever it wants, right? And so that can make people really sick. The other thing is that all cancers operate within the context of the body's physiology. And one of the things that you learn when you're a doctor is that every part of the body's physiology affects every other part of the body's physiology. And so anytime you have a cancer that is causing effects over here, sometimes those then cause other effects over here that cause other effects over here that cause other effects over here. And so that can become very complicated and usually does, even if the cancer itself is not, say, producing a hormone.
So given the overlapping nature of these systems, how do you tailor treatment plans to fit the specific needs and circumstances of individual patients?
Yeah, so that's a really complicated question. And in some ways, if you want to become a medical oncologist, you do 4 years of, at least in the United States, you do 4 years of undergraduate degree, then you do 4 years of medical school, then you do 3 years of internal medicine, and then you do 3 years of oncology. It's a lot of years. And in some ways, those last 3 years of oncology training, really what you're doing is basically one of the two or three main things you're learning is how to answer exactly the question that you just asked, which is how do I tailor treatment to the specific person or the specific cancer? There are a lot of factors that we take into account when we think about that. So, one of the factors that we take into account is the cancer itself. What is its genetic profile? What mutations does it have? What does it look like under the microscope? Then we take into account where the cancer is in the body. So, is it just in one place where we can take it out with a surgery, or has it traveled to other places and we need to use, say, chemotherapy? And then the third thing is the person who has the cancer, right? So we also have to think about, is the person young or old? Does the person have a lot of other diseases? Does the person have, do they live in a place where they can get to chemotherapy appointments, reliably? All of those kinds of things go into the decision that we ultimately make about what kind of therapy should they get.
On the note of side effects, what are the main side effects of the treatments for GI cancers, and how do you help patients manage those while maintaining their quality of life?
Just like every cancer is unique, every treatment for cancer is unique. And so, even if you just are talking about GI cancers, we often have, I've never counted them, but let's say 15 or 20 different drugs that we use to treat GI cancers, and each of those drugs has its own set of side effects. And then if you get radiation, that has its own set of side effects. And then if you get surgery, that has its own set of side effects. And so for all of those reasons, there's no way to really say, well, treatments for GI cancer in general have the following side effects. Rather, that's just one of those questions you have to talk about with your oncologist.
What are the latest treatment advancements in GI cancer that patients should be aware
Well, that's a little bit of a complicated question. In some ways, you could argue that the most important thing is that people should know that the age at which you should start a regular screening colonoscopy is now 45. It used to be 50, but we are seeing more colon cancer in younger patients, and so we now encourage people to start at 45. That's one important thing. And then in terms of the treatments that we use, probably the most important thing in GI cancers, as it is for many other cancers, is the use of immunotherapy. So, traditional chemotherapy works in effect by sort of poisoning the cancer cells, but that also has the side effect of poisoning some of the healthy cells in your body, often, not always, but often. But now we have this new kind of therapy called immunotherapy, which instead, in effect, weaponizes your own immune system and convinces your own immune system to fight against the cancer. Of course, as with any treatment, it doesn't always work, but when it does work, it can be pretty dramatically effective.
And how do you decide whether a patient is a good candidate for those newer therapies like immunotherapy, as you said?
Yeah, that's a really good question. So the short version of that is that it depends on multiple factors. One is the kind of cancer. So some kinds of cancer like melanoma are almost, I shouldn't say always, but are often um, well treated with immunotherapy. That is to say that immunotherapy works in a very high percentage of patients who have melanoma. Other kinds of cancer, like, say, pancreas cancer or even colon cancer, immunotherapy only works in a pretty small minority of patients. And so it really does sort of depend on the patient. And then in some cases, we look at the tumor itself and look at the tumor's DNA. We can do tests to look for particular mutations and only so, for example, in colon cancer, immunotherapy does not work most of the time, but if a patient's tumor has a particular mutation, then that lets us know that it has a better chance of working.
And what role do clinical trials play in your practice, and how do you recommend patients consider participating?
Yeah, so a clinical trial is a very carefully controlled way of determining whether a new drug works to treat a given cancer. And so we do recommend that people participate in clinical trials. In order to participate in a clinical trial, your case has to fit into certain very specific parameters. So often a patient won't have a clinical trial that's available to them. But if they do, the hope is that it benefits both parties. It benefits the patient because they get access to a medication they otherwise wouldn't have access to, and it benefits future patients by helping us to know which treatments will work for a given kind of cancer.
Great. Thank you so much, Dr. Johnson. That's all the questions we have for today. It's been a privilege meeting you.
Thanks so much, Linuki. It's been great to be with you.